Hi, doing? My name is Tom Willman from Apex Orthopedic Rehabilitation in Wyckoff, New Jersey. Today, we're going to explain how we do a McKenzie evaluation. It's a particular type of evaluation for spine or extremity type problems. And a lot of people have come up to us saying, how do you do an evaluation? How do you come up with an exercise or treatment plan? And also, how do you know whether I'm appropriate for physical therapy? So at the end, you're going to understand how we come up with that, and you'll understand the path and the exact method. So the McKenzie Method was developed years ago by Robin McKenzie. He came upon this system of evaluation. He worked with a lot of people actually with lower back problems, but this method is often used for neck, upper back, extremity, like we talked about shoulder issues. But he was treating a lot of people with lower back problems, like people with bulging discs, herniations, stenosis, various problems like that. And he came with this systematic evaluation to find out whether a patient is appropriate, for physical therapy, and also how to evaluate them. So we're going to go through a little scenario right now explaining how we go through this evaluation method. So Thomas is going to be our sample patient today. He's going to we're going to take him through a few movements. The first thing we're going to talk about is we got to find out what that patient's goals are and find out what their expectations are. Make sure we're in line when we first start out. And the other most important thing, or very important thing, is the patient history. And what that means is this patient might be coming in, let's say, with a lower back problem and leg pain. Let's give you that idea. Let's say he's got right leg pain to his knee, lower back pain. That's what he's coming here for. We're going to talk to him about a few things about that. We want to know this person as a whole patient. We want to understand what they like to do, what's their average day like. So this is a McKenzie evaluation form. We'll show a little clip of it in the notes and all that. We'll take a little picture of this as well. Okay, so this is a standard McKenzie form that we use here, and it kind of walks us through the start, getting to know the patient. First thing is we want to know how old they are. Certain problems are found in certain age groups more than others. If you have someone as young as Thomas, he's someone that doesn't have certain conditions as much. He may have other conditions that are associated with younger individuals. All right, so we want to make sure that's why the age is actually very important. We also want to know where they came from. Did they just come here by themselves? They said, I had an achy back and leg, and they just showed up at your door. We see people, and those people you have to be a little more careful about. You want to make sure you screen for them and make sure they're appropriate for physical therapy before you start. That's why you have to talk to them first. Sometimes we refer from, let's say, they're orthopedist and they've had imaging, they've had x-rays or MRIs, they've had other things beforehand. And that's some of the information that we want to collect as well, and we encourage people to bring that on the evaluation. It's not absolutely essential, but it's good for the overall picture. Next part is just, what do they do? What's their day like? Thomas is a student in high school right now, about to graduate. He, his day is probably sitting for during the day a lot, but maybe he has some sports after school or things like that. We want to know what his average day is like. That's very important as compared to, let's say, a construction worker, which is standing, moving, and he's actually very active, less sedentary during the day. It tells us a little bit about expectations as far as the patient. Another part is leisure. What do they like to do? Do they like to sew? Are they a big gamer? Do they play frisbee football? What do they like to do that we want to get them back to, and we want to realize that they value? And that's very, very, very important. And that's what comes from the history, is talking to Thomas and any patient. And then, so first thing is we want to say, hey, what are you currently feeling right now? You want to know what they're starting with. They call it a baseline. The baseline is just kind of like what you're feeling today. They might be coming in and today is a good day. And we want to know if it's a starting point. Are they having any pain at this time? And you'll say, today's a good day. I don't know. You go to the doctor and you're feeling good. That's how it works. Or they're having a really bad day. You'll see that they're kind of limping in and they're having some trouble. We want to know what their present symptoms. Let's pretend that Thomas has back pain, a little hip pain here, radiating to his knee. And and what will often happen is people say, I don't know if this is a knee issue or a hip issue or a back issue. They're kind of like, I don't know what it is. All I know is this is what I'm feeling, okay? So you want to know the present symptoms and also kind of things that they can't do because of it. Like, what's their functional limitations? Like, I can't sit more than 15 minutes. It kills me. 5 minutes is okay, 15 minutes kills me. Driving is the worst. Okay, and you note that in the evaluation. And it also gives us an idea of where they're starting. And hopefully as they improve right away, we'll say, well, now I can sit for a half hour. And you've noted this is where they started. We want to know when actually this began. Okay, so we know what their symptoms are. Let's say they came and they feel pretty good today. But when did it start? Was it 2 months ago, a year ago? If it's right at the start, they just fell down the steps 2 days ago, we probably want to be a little gentler with our evaluation. We may not even want to evaluate. We may want to send them back to their orthopedist for an x-ray. So we want to know when this started. I call it the golden question is, what happened at that time? Did something actually change? Did you start a new sport? Did you do a new CrossFit workout? Or did you just, maybe you were more sedentary? We've noticed with certain people that's actually during times that they're more sedentary, some of these spinal problems come up. So we want to know really what was going on at that time. Sometimes there's no real reason. They just said it just showed up and the patient doesn't know. But you got to ask them those questions. Sometimes they don't even realize it. So we want to know when it started. Is it improving, unchanging, or is it getting worse? So we kind of get a sense of what's going on with it. Is present, and was there any particular reason, like we said, was there any reason why it occurred? All right, so what we want to know now is, let's say the person comes in, you want to know whether they have constant symptoms or is it on and off. So Thomas just came in, let's pretend he had pain right now, but you say, well, do you have pain all the time? Well, yeah, I have like an hour or two sometimes in the morning where I don't feel anything, but typically towards the end of the day, I start having more problems. Okay, that's good to know that. So there's periods of time where he feels good, so that's part of the information and part of what they call the clinical picture. All right, constant or intermittent, that's important. And then the other section is what's worse and better. I'll say, what makes it worse? Like we talked about earlier, when I drive, it's really bothering me. Okay, we note that in our form. Is it worse in the morning as the day goes on, or the evening? Or is it better in the morning? Okay, is it better with standing, walking? We're trying to see if there's a particular movement or position of the patient that makes them feel better. Anytime they're sitting or driving or crouched over or tying their shoes, when they're forward, that's worse. Or is it more when they're standing and erect or they're more upright? Wow, that's worse for me. So I would say patients know more about their condition than anyone. They know they're living with this condition, this problem all the time, and they know if you listen long enough, any patient will teach you how to treat them. You just have to listen and hear how this thing is bothering them, and you can learn a lot from that, even more than the clinical exam when we actually move them around, because we have, like, say, months of information as compared to just a half hour. So that's better or worse. We want to know if there's any disturbed sleep. Sometimes if they really have a lot of pain at night, that's a sign of like cancer and infection, like a serious problem. So, we want to, or do they have any fever or anything like that? That might be a sign of something that's going on that's not mechanical or something that a physical therapist can help them. We have to refer them back. They may not realize that this is, connected with a problem. So sleeping postures, do they like to lie on their back, their side? Like, what's their preferred position? Especially if they're saying they're waking up with a lot of pain. Previous history is a great thing. So previous history means like, okay, so Thomas said, hey, I had this maybe 5 years ago when I started lacrosse. I started developing this problem, and then it went away, or I received treatment. Find out what they did before, and maybe if you learn a little bit about if they've had previous episodes of this and history of it. And that tells us a lot too, especially when someone that's a little bit older, let's say my age and such, they may have had this happen a few times, and you learn a little bit about those previous episodes. Also, you may learn, I tried this and this made it better. Oh wow, okay, maybe we'll adopt some of those strategies and use some of those things. And what previous treatment? Some people have tried acupuncture, chiropractic, another therapist. Sometimes we see people that come to us for an evaluation and they've tried therapy before and they've actually changed therapists. And I always say, listen, well, what didn't work? Okay, well, what did you do before? Oh, I never did the exercises. Okay, well, maybe we have to do the same thing, we just encourage them to do it. Or I did a particular type of therapy. Like, well, if that didn't work, maybe that's not the road we want to go down. Maybe that's not the solution to your problem. So you learn a lot from how they've been treated before. Other questions we want to ask: does it hurt when you cough, sneeze, laugh, anything that kind of increases the pressure around the spine? That's a really important question. It talks about sensitivity. They're very sensitive with it. That'll tell us a little bit about how we should treat them. We want to know if there's any abnormal bladder function. Sometimes with back problems, there's a serious condition called a cardiac equina syndrome, and we want to make sure there's no bowel bladder changes, and that's a very serious thing that we want to get you to the doctor immediately. Is there a gait thrown off or anything like that? Other things, medications. What are they taking? If they're taking steroids at this time, or Advil, what are they taking? It tells us maybe they're not feeling pain because they just took a bunch of steroids, and that's not a good indication of like how he's feeling. Also general health, any history of cancer, stress fractures, bone density issues. Those are also some things we have to consider when we do our evaluation before we start treating them. That's why we have to talk to them first before we actually have them move. Any imaging? Did they receive an X-ray, CAT scan? Some people went to the ER and they got an X-ray. Maybe they didn't, but you want to know what they did and what the results of that study was. Any recent history is another thing. If they had a recent nerve surgery, sometimes you'll have an infection related to that surgery, or there's something that's occurred after that. Unexplained weight loss is the I wish question. Sometimes that's an indication of cancer or some kind of serious pathology or problem. So that's the main questionnaire that's in the front here. Also, we'll ask them, we'll have a little diagram you see in the corner here of their symptoms, where are their current symptoms, and it's just a little thing here, it's just a little body here. It just tells them where they're feeling it and how they describe it. Do they describe it as numbness or tingling? Do they describe it as achiness? Sometimes the way the person describes this tells us a little bit about the type of problem. So that's important too. That's the first page, and that typically takes about maybe about 20 minutes. It can go longer or shorter depending on the person. Okay, so that's our history, which is the most important part of starting any treatment for anyone. So first thing we want to kind of take a look. How does their posture look? Are they kind of slumping during this whole time we're talking with them? Are they very erect? And see what their sitting posture is. We'll kind of see how that looks. Standing posture, are they, when they walk in, were they shifted to the side, or do they have any kind of like abnormality or anything that kind of tells us there might be something going on as far as the lower back? When they first start, we'll say, okay, you're having pain in your leg right now. Thomas has told us already, hey, I've got some back pain and I've got some thigh and knee pain. When we make a little correction to their posture, he's sitting forward, we have him sit up and say, okay, sit up for a second. Does that change your symptoms? What you're coming here for? And they'll go yes or no, and it tells a little bit about it. Sometimes just a little correction of posture, they go, wow, it's turning down the volume of that pain. I feel a little bit less. That's a sign that maybe there's something mechanical, movement based that we can give them to work on. And it just tells a little bit about it. Now, after that, we'll kind of note that on the form. We will occasionally do a neurological screen. All that means is we're doing a screen for any kind of real serious involvement of a nerve. Let's say a nerve, they call it about a pinched nerve. Nerve is really getting pinched. We'll do a quick check of their strength and their reflexes, and also check their sensation. So we'll just go through that really quickly. So Thomas is just going to sit up here. I say sit up nice and tall. You can put your hands at your side and just move that out of the way. And I'll say, okay, bring your leg up like so. Okay, hold right there. Good, and then we'll check the opposite side. And we always check both sides for symmetry. I'm more concerned about symmetry. Some people are just weak on both sides. He's really strong. He's symmetrically strong. Hold right there. Don't move you. Hold. Good, hold. And this shouldn't take long. You'll feel very different. I'm not talking about weak. I'm talking about when you test someone that's got a neurological or nerve weakness. When you test them, let's say hold, don't let me move you. Now I want you to pretend like you're a little bit weak. You'll feel like just let the leg fall. You'll push and they really just give away. And they'll talk about it. They'll say, when I walk, I feel like I'm a little clumsy, or I can't quite control my leg. That's a sign of weakness. A couple other areas, bring your foot up, hold right there. Toes up, hold right there. I'm not checking the other side right now, but this is something that turn your foot out, hold right there. Turn your foot in, hold right there. Curl your toes, hold right there. I would compare to the other side, but for the sake of the evaluation today, that's basically what we do. But we're looking at both sides and we're looking for symmetry. We're any true weakness. And if we're unsure, we'll do it a few times. We'll say, okay, test it, resist me, resist. And after a few times, you'll notice they get weak really fast if they truly have a nerve-related problem that we maybe want to talk. And then they'll also describe it, say, wow, I've been getting weak very rapidly recently. Like last 2-3 days, I'm getting really weak. That's a sign we probably want to send it back to their doctor or ER pretty fast if it's occurring rapidly. If it's just kind of there, that's not as much of a worry. We want to check their reflexes. This is called the patella tendon, this little tendon here. We'll just check their reflex here, and we'll check it at the Achilles here. That just corresponds to nerves coming from the lower back. Okay. Occasionally we'll do sensation testing. I typically do it with a sharp probe like this. I'll just do it at the end here, or this roller, and I'll compare. I'll say, how does this feel to either side? And I'll typically do that in the areas that they say they're having trouble. And they say, wow, that side feels a little bit different from that side. It says, and we'll compare different areas. We'll look sides here, top of the foot, sides here, depending on what he tells me in the evaluation sometimes as well, okay? And that's just a quick, and they're just checking for sensation. So that's a neurological exam. Let's say that's good. Thomas doesn't have any problems. He's feeling pretty good. He tests strong. He just has some pain right down his leg. Okay, so we move to the next step. So we're gonna have Thomas stand up, and we're going to have him just do come out a little bit further here. First thing we're going to do is, okay, what are you feeling right now? He says, oh, I still have that pain right down my leg right to here, and it's in my back right here. That's fine. So what we're going to first do is just going to have you bend forward as far as you can and run your hands down in front of your leg and go as far as you can down and then back up. So let's try that, Thomas. And you say, hey, you feel any increase in pain or anything like that? No, it's about the same. Now put your hands on your hips and I want you to lean backwards as far as you can. He's actually a little tight, you know, for a young guy, he's a little tight. It might be just because he was just sitting there for a little, you know, for a period of time. Now what we're going to do is we're going to turn and we're going to face this way, and we're going to side bend to the right. Run your hand down the side. Good. And he's getting to right about there. Now let's compare to the other side. And he's about to there. So it looks pretty symmetrical side to side. Another way of evaluating is we're going to have him do a little side bend. I'm going to show it first. We're going to side bend to here, pushing our hips to in, and pushing our hips there. Okay, so let's try that, Thomas. Just come a little further over. So side bend to one side. Good. And then take this and side bend to this side. And we're looking for symmetry. It's a little bit different when we look at that in that way. And then also we'll look for a little rotation. So cross your arms like so, and we'll rotate to one side. Good, and then rotate to the other side. I'll just check how that looks. Okay, looks pretty good. So that's basically we're getting a baseline of how far he's moving. For him, he's got pretty good, he can go pretty far down that way. Nothing kind of changes his pain right now. He's a little limited in going back this way with a cold extension. So let's turn this way. Let's check that one more time. So hands on your hips, and let's lean back. So he's right about there. I'd call that maybe 50, 75%. Okay, so I would say it's a moderate to minimal loss of motion. Okay, so that's, we're going to note that on here. And we're also going to make a little notation. He has pain when he goes forward if he does. He has any kind of change in his symptoms when he just does the initial range of motion evaluation. So that's our baseline. We know that's where he's starting. We also know that he still has some pain on the side. Okay, good. So now what we'll start is now we want to see if we can move him a few times and see if there's any change in his symptoms. He still has pain in his back, hip, and knee. It's all the way down here, but it's not below his knee. So as we're going to do the motion, we normally start with going into, let's start with flexion first. So we're going to start with first, so Thomas come forward. Hands like this, and you're going to run it down. You're going to go as far as you can until you feel the very end, and then back to the starting position. You're going to do that 10 times. So go all the way down, all the way back up. And you want a little pause at the very end after 10. Once we get to 10, let's pretend he got to 10 already. Okay, you got to 10, okay. So I'll ask him, say, you know, during the exercise, was there any change? Yeah, it kind of hurt a little bit when I was going into there. It actually started going below my knee. That's considered a bad sign. If you have pain moving away like that, going further down into the leg, that's typically a bad sign. They call it peripheralization and centralization, which is on another video of mine. But that's a bad sign. So we're probably not going to do that movement again because it seemed to make him a little worse. It said, let's pretend that he said the thigh pain actually got a little worse. It was a little bit more severe, and the leg pain started developing pain below his knee. Let's not do that movement again. All right. So we're going to try another movement. We're going to try extension. So we're going to place our hands on our hips. Go a little further. Let's do it from a side view right here. Now I want you to arch back, go as far as you can, pressure on, and then pressure off. Let's do that 10 times. We'll just do it 5 for that. And we want to see, one, is there a change in his motion? Maybe he's going further after doing this. Let's pretend he did 10. Okay, so he did 10. I don't think he improved his motion at all, maybe a little bit. Was there any change in their symptoms? Oh, wow, you know. Actually now, the pain that was down here when I started is now up to here. I no longer have that knee pain that I came here for. It's up to here. That's considered a good sign. So maybe we want to do more. So if we went through the whole evaluation, I'd probably have them do another set of 10 repetitions. I may even have him hold it for a little bit at the end of the motion to see if we can get that to the point where it moves even further up. Now it goes, let's say we did another set of 10. This is in a good scenario if someone's responding to the movement. Oh, and now it's into the hip, it's no longer into the thigh. Well, this might be a movement, this might be the movement that Thomas goes home with and he does on his own. Okay, and that's what we're trying to figure out. Which movement is good, which movement is bad, which movement doesn't do anything. Okay, so those are the two movements. Occasionally, we'll have people do side bend motions, and let's say both of those movements he didn't like. He said both of them made the pain worse. We may actually have him do a side glide movement. Let's say we do this movement. Let's say his pain's here. We'll do a side glide just to one side. Here, and then back. Here, and back. Sometimes that's the movement. It's not as common as the other two movements, but that might be the movement that reduces his pain. Okay, let's say nothing's working. Everything's making everything worse. Okay, so then the next part is we go from a standing evaluation, we do some things lying down on the table. Okay, so now we did something in standing, which is weight bearing, and now we're going to do something in non-weight bearing, kind of lying down. We're going to do a knees to chest. You're going to put both your knees towards your chest. You're going to put your hand like this, Thomas, and then the other hand like this. And you're typically going to bring your knees up like that, so you're kind of flexing. Now we're moving the back in the other direction. Instead of arching the back, we're flattening the back. And release it to here, and then back again. So we can do this a series of 10 times. We often have they stay on the table for about a minute to kind of start out like where is the pain at the current time, or what are they feeling at this time. Once we get to 10 repetitions, let's pretend he did 10. Lets his legs come out. We say, okay, what happened after doing that movement? Nothing. That really didn't make it worse, but didn't make it better. The next movement we typically go through is lying on your stomach. So let's have you lie on your stomach. People that are big yoga people will refer to this as a cobra, or a version of a cobra. So we first start out, we have them lie flat and say, okay, what's going on as far as the legs? I feel actually pretty good in this position. It doesn't feel as intense. Let's say the pain in his right leg, instead of being in the front of his shin, now it's back to kind of right here. Okay, so we'll lie flat, put our hands in front of our shoulders like this, like you're going to do a push-up. I like to widen the legs a little bit when we do this particular one. And what he's going to do, he's going to press up, and we got to monitor what's he feeling in the leg, and then after he does the movement, does it change? Better, worse, and no difference. That's all. So let's press up like you're doing a push-up, but you're not going to let your hips come off the table. So you're going to push up, a little pause. Let's imagine that's it looks like that's as far as you can go. Then you're going to come back down. So you pause a little bit at the top and slowly release it. All the way up, and then back down. Good. So we're going to do a series of 10. Depending on what he feels, let's do one more. And eventually, like most people, eventually can get to the point where they lock out their elbows. They go, let's try one more. Try to go as high as you can. And then back down. So occasionally, people say, wow, I can go further. My arms aren't long enough. And we'll actually give them like a half roll, something they can put their hands on so they can go a little higher. And here, we'll actually lift this table up like this. Come forward a little bit. We want his waistline right at the break of the table. So come a little further forward. Good. Now put your hands like so and push up. You notice with some of our people that are very mobile, to get to the very end of the motion, we have to get them a little higher. So we'll elevate the table or even use like a foam roller underneath their hands. It depends on the person. You'll notice with certain dancers or gymnasts, we need to do that. For him, I don't think we actually have to do that. So I'm going to lower this back down. All right, so let's say he did 10 repetitions. He says, wow, this is actually out of my leg. It's no longer, because it's his right leg we were talking about, it's no longer there. It's actually just to the side here. It feels like a hip issue, actually. And some people say, I have an IT band issue, or I have a popping hip. And actually, we're moving the back, and all this pain is coming up. That's a good sign. Now he has just pain in there. So what do we do? Okay, let's say that's we don't have any more time for the evaluation. It seems like he likes this movement. What we normally do at that point is we send him home with a prescription or a plan. So we'll say to him, let's have you sit up. We'll say, we want you to do this movement. You just did that movement. You seem to feel better after doing that movement. You seem that your range of motion also improved. I think this is a movement that we want you to do throughout the day, okay? So I'll typically tell people do this 10 times every 2 hours. So we want about 5 sessions a day, and that's typically a sweet spot. And we want to do it throughout the day. We don't want to cram for the test and do all the stretches at the end of the day or at the start of the day. Typically it's better just to filter it out. Some people are very sensitive. They can't do 10. They're going to do maybe 5 every 2 hours. Or they're kind of nervous. So I say, well, start out, do a couple and do 5, and because you get more confident, it's not bad, it's not making your condition worse. we do more. So try 10, 20. I say not more than 20 is probably that. I wouldn't go higher than that. After a few days, three to 4 days, I typically like to have people come back in, sometimes earlier, but three to 4 days is a good time period, sometimes a week. And then we recheck them and say, hey, how did that movement go? Like, how are you feeling with it? Do you feel like it's improved the frequency of the pain, the duration, how long it lasts for, the intensity? If any of those three things change, then we're probably onto something. What we didn't talk about is that when we looked at his things that he likes to do, like he's a student, he sits a lot, we're going to say, hey, with your sitting, let's break up your sitting. Can you get up just every 30 minutes or 20 minutes, get up and move around a little bit, just to take you out of a position that tends to bother you. If he does other things, let's say I know he likes to work out, maybe he has a gym program, maybe he says, every time I do sit-ups, it seems to give me this leg pain. Maybe we take that out for now, and we have him other things to do in the gym, or we modify his gym program so he's still active, but we're taking out things that might be triggering his symptoms. So sitting, let's say he does Russian twists or a lot of like abdominal exercises, and he says, that always bothers me. We take that out for a little while and see how he does. Okay, but eventually we want to have him get back to all these things. And just temporarily, we want to break that cycle of pain. Let's assume he's had it for 3 months. Okay, so we're trying to break that cycle, and then slowly, as we see if he responds to this way of treating it, then we retest him, and then we start stretching everywhere. We do other things, and we reintroduce all the activities that he wants to go back to, depending on the person. First thing, so that's some of the things we want to look at. But the first thing is to start with a movement, and hopefully we find a movement that the patient feels better with. There are people that don't respond to this method. There's times that they just, they are a non-responder. And back pain is multifactorial. It's a lot of different influence on back pain. It could be stress. It could be hormonal. It can be related to, unfortunately, a high BMI or if it be obesity. It could be a lot of different things that can affect this. We're trying to see if it's a movement or a mechanical solution, a movement or something that's tight that we're trying to loosen to make them feel better. Okay? So we have to consider that when we're treating the patient. Sometimes it's not related to a tight hip or a tight back. It might be related to some of those other factors. So we have to actually include that. Sometimes refer to a psychologist, or we have to refer to someone else to kind of look at that. Some of the other things we look at that's not part of the McKenzie method, we'll also say, how's your diet? How's your sleep? What's your stress like? We also try and address those other factors that can give you and mimic and give you some of these other problems as well. Last thing before you leave, also we have a patient that comes in here. A lot of times I'll ask him, is there any way that is there any particular movement or position or thing that you do that immediately turns up your pain or makes your pain come on or make it worse? Sometimes it's like doing a squat or walking up the steps. And we'll say, well, use that as your baseline. So if you're feeling better, check that. Wow, when I do steps now, it's better. That's a way of kind of giving them a way of self-assessing. So anyway, so that's the McKenzie method. One of the more common stretches, the one that Thomas is going to do and walk home with, he's going to do his prone press up 10 times. It should never make him feel worse. And we tell him if it ever makes it feel worse, it might be not the right exercise or you're not doing it right. And that's where we talk to the patients. We have people text us or reach out to us if they're not sure about, just to kind of walk them through. And if not, we get them in earlier if they're not responding. And if they're doing really well, sometimes we push a visit out. Instead of doing a follow-up in a week, we'll give it a couple weeks of them doing this movement. That's essentially it. There's other movements. I'm only showing you one that Thomas responded to. Sometimes the knees, the chest, the movement that he started with, or flexing forward like this. Sometimes I have people doing this for 10 times, and that seems to reduce their pain in their back. So there's a lot of different things that come up. A lot of times the McKenzie method is associated with doing a press-up and anything with arching, but it's really based upon whatever movement makes the patient feel better. So that's what we're really looking for in our first visit with you, okay? And if we can change your pain or have you feel better the first visit, often that's a good sign that we can help you out. If we really can't make you feel better or everything seems to make it feel worse, it's not always a great sign. It doesn't mean that we can't get you better, but I would say after 2 or 3 visits, we typically know whether we can help someone out using this type of approach. Anyway, I hope this gives you some more information on what the McKenzie method is, how we use it. If you ever seek care for this, so you're not in an area, you can't get to see me here, always look on the McKenzie website. We'll put that in the link in the bottom in the description, and it'll tell you how you can find a certified or a diplomat, a certified McKenzie therapist. A lot of people that are using McKenzie therapies aren't really certified, and you really need someone that knows and does this every day to get the best results, okay? To see whether it's actually appropriate for you. And if you liked it, this video and it gave you a lot of good information, I want you to like it, subscribe, and throw a comment in there if there's anything you have a question about, and I'll try and address as many as I can. Most importantly, have a great day and keep moving.